Good evening, everyone. So I welcome you all to this FB Live by Dr. G. Vishwanathan, CBCC Cancer Center 30. I hope all of you are safe and sound. So as we know today, our topic of discussion is advancements in cancer treatment. So for that, we have a renowned and experienced doctor with us, Dr. Arun Raja. So let me give a warm welcome to Dr. Arun Raja. Welcome, doctor.
Yeah, good evening. Thanks for your warm welcome.
Yeah. So, viewers, Dr. Arun Raja is a consultant medical oncologist at the Dr. G. Vishwanathan CBCC Cancer Center, Trichy. He completed his MBBS from Madurai Government Medical College and later obtained his DNB in radiotherapy and oncology in 2017. Dr. Raja also holds a DRNB in medical oncology and hematology. His areas of interest include breast and thoracic oncology, indolent lymphomas, leukemias, metronomic chemotherapy, molecular oncology, myeloma therapeutics, and immuno-oncology. So, doctor, we are glad to have you. Thank you for joining us.
Yeah, with pleasure.
So, doctor, any welcoming remarks for our viewers?
Yeah, definitely. So I thank personally our managing director, Dr. T. K. Govindarajan, and my medical director, Dr. K. N. Srinivasan, and our own CEO, Mr. Ramesh sir, for giving this opportunity to hold a position in CBCC. And I thank you all guys for welcoming for the FB Live. So these are the exciting days in oncology. The field of oncology has driven by many challenges, though in the cancer care. Still, we are the huge players and a comprehensive uh, cancer therapy. So I think we are in a topmost person in the world also, as you know very well. So so immunotherapy, CAR T cell therapy, and ADC, antibody drug conjugates. So many exciting days ahead in oncology, particularly in medical oncology. So we will discuss one by one. Then.
Surely, surely, doctor. It's a privilege to have you here.
Once again, thank you so much.
Yeah. So, doctor, we'll start with the questions.
Yeah, please.
Can we? Yeah.
Yeah, definitely. Go ahead.
Okay. So first question is, what are the recent advancements in medical oncology treatments for cancer?
This this we have a watershed moment in oncology. It means that medical oncology is jostling for the pole position among the three medical treatments, namely surgical, radiation, medical treatment. The medical oncology nowadays in 2023 we have very new fresh perspective in the treatment care, and we have a very clear moment of clarity. The immunotherapy has taken the world by storm. So the end of one size fits all era. So we are moving ahead with the truly personalized therapy. So the huge steps, huge gain leap in translation research in cancer treatment is going on. Now the era of precision oncology, already the molecular analysis for therapy of choice is going on all over the world. And artificial intelligence in cancer care, machine learning, and new developments like CAR T cell therapy and the genomics has taken the cancer care to next level. We are doing routine ENGS in this. To sum up, the medical treatment currently the immunotherapy is what to say, it's a biomissile in medical oncology. Next comes the targeted agents. Next comes that BiTE T cell therapy, then ADC, antibody drug conjugates, and we have a cancer nowadays we are coming with cancer vaccines. In Germany, the cancer vaccines are going on for glioma, which is hard to treat. So many things are coming up, the cellular therapy and immunotherapy. So they are taken the medical oncology to next level. From 2015, we are moving ahead in a fast pace than we ever imagined. So coming up to the basic cytotoxics, we have a huge number of molecules. Now our weapon against cancer, particularly in medical oncology, it has what to say. It's like Kali Mata's hands. You have many more options to treat the patient. forgot about first line, second line. Now we are moving how to make cancer as a chronic disease, how the patient can live with cancer for what to say, name few years without any complications. So there are exciting days ahead. I hope so. CBCC has a very good answer for cancer. I'm one of the fellows who gives the medical oncology treatment over here. So to sum up, so we have what to say, many options, many more options: targeted therapy, small molecules, molecular oncology, immuno-oncology. Even then, forget about all the new advances. Now the palliative care supporting care has gone to next level. So I hope that these are the recent advances going on. So in few years, we'll have what to say in the vaccines, immunotherapy, then recent addition of one or two molecules. For example, I can tell you that pembrolizumab is it's one of the immunotherapy agents. It has approved for 36 indications in the cancer. You can't believe that single drug for 36 indication in cancer care. That's a recent talk of the thing. Then you have heard few months before that Drosaltimab has cured the patient without cancer. That's in phase two trials. So these are the events going on in our own field. So I think that so medical oncology again, as I said before, it's jostling for the pole position.
Surely, doctor. So, doctor, my next question is what all treatments come under the umbrella of medical oncology?
So I can tell you that under the umbrella of medical oncology, I'll divide into three aspects in these questions. One is situation based. It's a curative. It means that we should get a control or cure of cancer. It is going to be palliative. The palliative means it's supportive to maintain the quality of life, ease of symptoms. Okay, this is situation based. Next is the stage based. So the chemotherapy will be recommended based on the type, stage, biomarker, age, comorbidities, overall health status. So, and based on molecular aspect also, basic cytotoxics, the novel agents like targeted agents, and top level agents like immunotherapy, CAR cell therapy, then antibody drug conjugate, bispecific T cell engager, then by mode of action, but matlab, it's a cell cycle specific, cell cycle non-specific. Then another thing comes to the as such treatment part. It can be a neoadjuvant. It means that before surgery, before radiation, we'll give a chemotherapy for the patient. Next will be the adjuvant. So we'll take out the disease by surgery. Then we will give the treatment for the microscopic disease. If it is going to have a stage 4 disease, we are giving a palliative chemotherapy. Means it's for to maintain the quality of life and ease the symptoms. Another comes in hematology is high dose therapy. It means that we just give the unimaginable dose of chemotherapy what we are giving in a day-to-day care. To in one shot, we'll kill all the cells and give a transplant to the patient. Another comes the CAR T cell therapy. We'll take the cells from the patient and infuse and genetically re-engineer, and we modify the T cells. Then again we reinfuse, and this T cell will make the immune system to fight against cancer. Next comes the targeted agent. It has own monoclonal antibody and small molecule inhibitors. So it means that what is monoclonal antibody? An antibody attached to a antigen. So it works like a chemotherapy drugs, but it basically re-engineered antibody. So it has a less number of symptoms compared to basic chemotherapy. These are the things going on now. Nowadays, gene inhibitors. Gene inhibitors means to next level. So if one gene is mutated, we'll screen the patient for the one gene, and then we design a drug. We If the drug is in phase one or phase two study, we just get by compassionate services. Then we'll give to them to ease the symptoms. We'll see that whether it works or not. This kind of the treatments are going in medical oncology. Imagine in 2005, the medical oncology has handful of drugs. In 2015, the landslide even happened. So in 2015 to till now, we have huge number of drugs available for the treatment. Unimaginable. So many hard to treat malignancies are becoming a cakewalk for us. This is the things comes under the umbrella of medical oncology. I hope I answered this
Yes, yes,
question.
surely, doctor. Yes. So, doctor, my next question is What is chemotherapy and when it is suggested?
Okay. So chemotherapy, if you divide chemo slash therapy, chemo means any chemical to treat a patient. So it's a generic term. But conventionally, what happened? The chemotherapy became attached to only cancer care. So the chemotherapy, it's synced with the cancer care. So chemotherapy means any chemical used for treatment. That is the definition of chemotherapy. Again, it is used for three situations. One is for control the disease, one for cure the disease, one to ease the symptoms. So it will be suggested based on the stage-based basis. So, for example, if a stage one malignancy after surgery, if you are giving for the adjuvant chemotherapy, for example, for breast cancer, all all breast cancer more than 1 centimeter will get a chemotherapy. So it's adjuvant. So another thing is concurrent. Concurrent means we won't go for a surgery. We'll go organ preservation therapy by using radiation and chemotherapy. So the chemotherapy will be given based on the body surface area. So then it is suggested in concurrent setting also. So I explain adjuvant. Adjuvant means after operation. Concurrent means we don't operate the case. We just mix with the radiation and give to the patient. Another is neoadjuvant. Neoadjuvant means you just make downsize the tumor. If the tumor is 4 centimeter, if it is going to be a risky for operation, we just give the chemotherapy before surgery. So we will make sure that the 4 centimeter comes to sizable, what to say, for example, 1 centimeter, so we can operate easily without complication, uh, without any injury to the nearby structures, without with the hope of preserving many organs, with the hope of giving a good oncological outcome. So that is the policy of neoadjuvant. Another thing comes a palliative metronomic chemotherapy. So what is palliative chemotherapy? Stage 4 disease. So the essentially the cancer has spread to all the organs. What happens in this situation? It is decided by the patient and the doctor and the family whether to give to maintain the quality of life. It means that the quality of life will not be disturbed by chemotherapy. So the quality of life will be enhanced by the chemotherapy, but the cancer will be will make sure that cancer stays on the stage itself. It means that it will give some kind of troubles, but the trouble will be eased by chemotherapy. So that is a palliative chemotherapy strategy. Another comes metronomic chemotherapy. So we metronomic chemotherapy and maintenance therapy. So metronomic chemotherapy we mix with a handful of drugs, 1 or 2 or 3 drugs. We just give in a low dose for prolonged period of life. It means that until the patient lives, he'll be taking the drugs. So the cancer will be listening to the drugs. That is a we call it a metronomic therapy as a tune for the dance. So we'll make sure that the cancer dances to our tune. Another comes a maintenance chemotherapy. So all the diseases out. We just give the chemotherapy, maintain the disease as nil disease, and to prevent further recurrence, we'll give a maintenance therapy. For example, in breast cancer, hormonal agents are given as a maintenance therapy of 5 years. Now they're recommending for 10 years. Now for ovarian cancer, where the cure is rarely curable, now became a what to say the maintenance PARP inhibitors, new molecules are incorporated in the treatment. So the patient, instead of what to say having a recurrence now, they will be having a recurrence later after 5 years or 6 years or 3 years. So the maintenance chemotherapy, it maintains the disease in as it is. It means that like a fridge, it preserves the fruits or vegetables. Likewise, the targeted agents or chemotherapy as a maintenance, it preserves the cancer as such. Sometimes it is curable also. In immunotherapy, also the same story. Immunotherapy makes our own immune system to boost up and fight against the cancer. It means that it boosts the immune system to fight. Nothing doing with any cell killing or anything. Just our immune system fights for ourselves. So these are the things. Basic chemotherapy will be combo immuno and chemo combos nowadays coming up. It means that chemotherapy will be given for cell kill and immunotherapy will be given to boost the immunity. So what happens? A dual effect. It's like it will like brothers, they will fight for their war.
Okay, doctor. So, doctor, as you said, immunotherapy is a kind of therapy that boosts your immune system to fight the battle against cancer. So,
Yes.
does it has to do anything while the patient is undergoing cancer treatment, or it is given before if the person has a risk of getting cancer?
No, no, no. Right now, we are using only for to treat the disease and maintain the disease. Nothing to
Okay.
do prior the disease. So there
Okay.
is no real world evidence or phase three evidence to show that immunotherapy before cancer. So those who have risk of cancer, immunotherapy should be given likewise. There is no absolutely no role. So the only role is once a cancer is diagnosed, we'll do a basic test. In that, we have some kind of PDL1 test and many NGS tests, tumor mutation burden, some kind of these are medical jargons. So these are tests we will do, and based on the eligibility only, we will use the immunotherapy. So immunotherapy cannot be used randomly. So
Okay.
though it boosts the immunity. So the thing is, no, it won't fight for the cancer prior having a cancer.
Okay. Okay. Sure. Okay, doctor. So, doctor, next question is there's also a type what is a targeted therapy in which cancers are treated by it.
Yeah, targeted agents is nothing but just to hit the bullseye. It means that we find a target, we hit the target. So nothing
Mm-hmm.
doing with the rest of the cells. It means that, for example, I'm telling. So the patient has a lung cancer. He has only one mutation. We give the drug, it will take care of the mutation. So if we give chemotherapy, what will happen? All the cells, blood cells, then what to say, white blood cells, platelets, everything will be dead. So neutropenia, again infection risk, but in targeted agent, we just just I can tell that it is 5 to 7 it is eliminate certain extent. So we can use targeted therapy to hit the target, and small molecule inhibitor. Small molecule inhibitor, it has a multiple targets. So in a cancer, not even one target will be activated. It has many more targets. So one drug will be acting on multiple targets. We call it
Okay.
yes. Now we are going to tissue agonist therapy. It means that, for example, you take a cancer. If the cancer, we'll find a target. We hit the target. If we have one or two, three targets, we'll mix the targeted agents also. That's kind of events are happening right now. For example, I can tell you. So CML, it's a chronic myeloid leukemia. So we have a target. BCR APL target will be there. So we give the tyrosine kinase inhibitor. So the patient will live like a hypertensive diabetes, taking a drug without any issue. So even they can give a child, they will have their own child, they can have their family. So this kind of events are happening. So another, in lung stage 4 lung disease, previously if you take 100 patients, only handful, 20 patients will be alive. This is a story in 2001. Right now in 2023, if you take 100 patients, if we have a target, we can make the patient to live for 36 months. It means literally 3 years. I'm telling with the median. It means that we can tell that out of 100, the median 50% can live for 36 months. That's a huge achievement from 6 months to 36 months. So likewise in breast cancer, we have a target for HER2. HER2 target around 20 to 25%. It means that if you take 100 patients, 25 patients will be HER2 positive disease. So we have a targeted agent. It is used for neoadjuvant, adjuvant. It means that before surgery, after surgery, and maintenance. It will kill all the targets. The patient will have a nil disease. I have seen patient who has a multiple metastasis lung, liver, taking the target agents for 2 years or 1 year, having nil disease, having a good life for 5 years also. This kind of things it's happening in the real world. So targeted therapy is another biomarker in cancer care. So we have around molecule monoclonal antibodies and small molecule inhibitors. Roughly around we have around 50 to 60 molecules in the market right now.
Okay, doctor. Okay. So, doctor, my next question is at what stage of cancer are any of these treatments recommended?
Yes, this is a very important question. So the stages, if you we know that the cancer has 4 stages: stage 1, stage 2, stage 3, stage 4. I'm telling about generic. So if you take any cancer, solid tumors, we have stage 1 to stage 4. So previously the targeted agents are used for stage 4. Now recently in lung cancer, we are using the targeted agents after surgery also. So for 36 months, you take the tumor out, you test for the mutation. The patient has mutation, give the drugs for 36 months, the patient will live longer for 10 years. So that kind of story is going on. Essentially, stage 4 disease, till now we are using, now we are moving from backwards to front side. It means that from stage 4 to stage 2, we are moving up. So for example, in RCC, renal cell carcinoma, previously the target agents are used for stage 4 disease. Nowadays, now the studies are telling it after surgery, you can give the target agent, you can prevent. So the first targeted agents like hormonal agents after surgery, so we check for the ERPR status, estrogen, progesterone status. We give the tablets. There are two
Okay.
kinds of tablets. We will use the tablets. They will have for 5 years. Nowadays, they're telling if you take for 10 years, even 10 years, imagine a patient taking 10 years tablet, having no disease, that too cancer. So even living good quality with what to say, maintain the quality of life, living longer. So almost it means that like a normal person they can live. So nowadays the oncology is moving toward a chronic disease status. Now from chronic to lifestyle disease we are moving ahead. It means that from stage 4 to stage 2 we can use the targeted agent based on the cancer, based on the stages, based on the patient profile, based on the mutation status.
Okay. So, doctor, next question is, do any of these cancer treatments have any side effects?
Yeah, this is a wonderful question. So we think that zero side effect, we should treat the patient, but it's a dream for every oncologist to treat without side effects. But unfortunately, every patient will have side effect. Okay, so target agents is not free of side effects. It has side effect comparatively less. It means that if you treat 100 patients, only 5 to 10 patients will have some kind of side effects. So side effects we will grade them to grade 1, grade 2, grade 3, grade 4. Grade 1 means almost negligible. It means that the patient can tolerate that grade side effect. Grade 2 means the patient can tolerate but with medications. Grade 3 means intolerable. Grade 4 means horrible. So hence most of the side effects falls in grade 1, grade 2 only. It means that they can continue the medication with supportive medicine. It means that they can maintain the quality of life better. They can have a side effects managed properly. So we are here to manage the side effects. So our own job is to console them and give them a good medication to take care of the side effects. So the side effects are negligible to targeted agents. Let me tell you that. So side effects in profile, if you take blood, so hemoglobin will drop, platelet will drop, infection will happen, neutropenia will happen in basic chemotherapy. In target agent, it is only 1 to 2%. It means that out of 100, we'll have 1 or 2 patients who will suffer this kind of side effect. The nausea, vomiting will happen in chemotherapy in almost all cases. But here in target agent, it is very minimal. It means that even 1 or 2 patients it may happen. So it means that it has something, but not that bad. Another the class side effects. It means that we have a target. So target has multiple function. We give a target agent. What will happen on target, off target side effect will happen. What is on target? So we hit a target, so the side effect will happen. For example, in lung cancer, we using a drug, it will give a skin rash, it will give diarrhea. These are grade 1. It means that it is manageable. So the risk benefit ratio and side effect profile will balance according to the disease state. It means that if the patient has side effect, still the patient is responding, still we are managing the side effect, the patient will go on with the same medications. So another thing, the pain may happen. It means that it's all are grade 1, grade 2. It means that all will be manageable without disturbing the patient quality of life, and they won't have hospital admissions. So that is the beauty of targeted agents.
Okay, okay, doctor. So, doctor, my next question is, are there any chances of recurrence after administering any of these treatments?
Recurrence, the fear of recurrence matters. Because for us also, it's haunting task. They will ask the question whether the cancer will recur again.
Yeah.
So we'll be what to say, will be in a critical position to answer whether we should tell the truth or false. But as per evidence, It is a foremost concern for both the patient and doctor. The fear of recurrence and the real recurrence are different. Okay, the real recurrence happens. It happens only in 7 patients of the curable cases. It means that if you treat 100 cancer patients, only 7 will recur if you treat properly. I'm telling that 100 curable early cancer cases, only
Mm-hmm.
7 may recur. This is the latest cancer recurrence statistics. Okay,
Okay.
but the fear of recurrence is almost 50% for all patients. So it also it varies between cancer to cancers. So I will give some statistics, so numbers. So these numbers, who has low recurrence? It means that around 5%. It means that 100 out of 100,
Okay.
5 will may have. So the breast cancer, Hodgkin lymphoma, acute lymphoblastic leukemia, these are very much curable cancers. The recurrence rate may be negligible to the tune of 5 to 7%. Difficult to treat
Okay.
cancers may have high recurrence rate. For example, soft tissue sarcoma, so they are difficult to treat. Then brain cancer, not all patients, but I'm telling roughly. Ovarian cancer, some pancreatic cancer, bladder cancer, the chance of recurrence are high to the tune of 30 to 40%. It means that out of 100 patients, 30 patients will recur. But these are based on the phase 3 data. Okay, if you treat properly, the chance of recurrence are negligible. Now the cancer treatments are moving ahead to immunotherapy targeted agents. So the new statistics will answer the new questions. I think personally the recurrence rate will be less if you treat properly. If you have all the drugs under your care, so if the patient is treated by a proper oncologist, if treated in a proper center like CBCC, so the chance of
Mm-hmm.
recurrence is going to be less.
Surely, surely, doctor. So, doctor, we are done with our set of questions. Our viewers have some questions, so let's take the viewers' questions. Can we? I think, doctor, your screen got stuck. So, viewers, doctor will be here in some minutes. I think he's facing some technical issues. So, please be with us.
Oh, sorry, we lost you.
Yeah,
Sorry, we lost you. No,
It's okay. It's okay, doctor. It's okay, doctor. That it's okay. So I was saying that we are done with our set of questions. Our viewers have some questions, and I can see Mr. Falgun Shukla is having some questions. So can we take it?
yeah, please.
Yeah. So Falgun Shukla, he is asking, what is the success rate of chemotherapy and targeted therapy?
Yeah, this is a very this is again going to be a number game. Okay, the
Yeah.
success rate in cancer. Success rate in cancer depends on three factors. One is the patient factor. The patient should
Okay.
have a treatable malignancy. Next is the social factors. They should come to a hospital. Third
Mm-hmm.
is the physician factor. So they should meet a proper doctor. If the three things meets, the success will definitely will happen. Okay, now next come the proper numbers. So, for example, breast cancer survival right now, this is a recent data I'm sharing with you. In 2023, the 5 year relative survival rate. It means that the percentage of people in treatment group who are alive after 5 years. You should understand that if you treat a patient, they should be alive after 5 years. Practically after 5 years, they are free of cancer. So in breast cancer, it is localized disease is 99%. It means that only one patient will score badly. So 99, we are in success rate in localized. Another comes regional disease. We have 85% success rate. It means that out of 100, 85 minus 100, it comes 15. So 15 patients, we lose the 15 patient, but still we can save 85 patients. So the 5 year relative survival rate is 85%. Then distant mets. So the patient already has all area, brain, liver, lung mets. They're coming to in a deformed state. Still, we have a chance of 26%. It means that out of 100, 26 patients we can save. So these are the number in breast cancer. For example, in second most cancer, colorectal. Colorectal
Mm-hmm.
for localized disease, we have 90 percentage. It means
Oh,
that
wow.
we can save 90 patients. 10 patients will score badly. That's a different story. But I'm telling about the 5 year. I'm telling about 5 year survival. It's not
Wow.
about a 1 year, 2 year. It's a 5 year. So localized disease is
Mm-hmm.
90 percentage. Regional disease, again we have a lymph node operator taken the chemotherapy very well. The success is 70 percentage, 70. If it is going by
Mm-hmm.
distance, it is 30 percentage. Even in distance, in colorectal, previously it was around 3 years only. Nowadays, they can live for 5 years. It means that
Wow.
the patient is diagnosed today with stage 4 disease, treated properly. In
Mm-hmm.
2023 to 5 years, it means that 2028 they may have a recurrence. That kind of advancements happen in our oncology field. So this is the numbers we have. For example, in hematology malignancies, so even in any kind of lymphoma, the 5 year
Mm-hmm.
survival rate for plus is 82 percentage. It means that out of 100, 82 patient we can save. So regarding
Okay.
distance, it means that lymphoma spread it is in somewhere else. Still, we have a chance of 70%, 70. It means that
Mm-hmm.
70 patients we can save. So 30 will score badly. So these are the success rate in cancer care. For example, in testicular cancer, our success rate is huge. It means the localized it is 99, even the
Wow.
regional it is 96, even at a
Mm-hmm.
distance it is 80 percentage. So
Wow.
these are the numbers rarely told by anybody because they never bother about the success rate. They all will tell about the loser quotient, but
Mm-hmm.
still the success in oncology is there. If you treat properly, again I'm telling that patient factors, physician factors, and social factors. If the
Mm-hmm.
patient comes early to a good doctor, to a good center, the cure rate and success rate will be there.
Yes, surely, doctor. So, doctor, next question we have is while undergoing chemotherapy, does the patient experience any mood swings or any other psychological side effects?
Even the diagnosis of cancer gives a mood swings for everybody.
Yes, true.
So, so imagine about the patient.
Yes,
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 the
yes.
emotional disturbance, mental changes, mood swings will happen, but it is poorly understood because we have a distorted picture. That is the problem. But I personally think because of two reasons, this kind of mood swing happen. One is the cancer diagnosis. The patient diagnosed with cancer, they will have a huge amount of what to say social pressure. They will have anxiety leads to depression
Yeah.
leads to distress, and then again environmental issue. So someone has a cancer, it's like what to say, their role in the society, in workplace, family, and caregivers mindset. This all adds up pressure to the patient. So the mood swings will happen not only because of diagnosis of patient. It is also based on the peer pressure or is due to the environmental pressure. So it's
True,
poorly
doctor.
understood basically. But the coping with mental illness with the physical illness is tough for all patients. But it can be what to say, it can be maintained properly, it can be managed properly if you have a if you break the gap by giving a proper
True.
communication. So even for female, it's a hormonal changes. So for example, the
Mm-hmm.
patient is a breast cancer, so we are giving hormonal pills. The hormonal pills will give a mood swing because of low sexual energy drive, cancer fatigue
Mm-hmm.
syndrome. That also gives a mood swings. So it has a multiple issue to deal with it. So I think that mood swing happens because of this. Then again, coming to the who will have mood swings. So based on the latest research, we can tell that young age will have a high mood swings because they'll be anxious. So everyone will be playing, I'm not playing. Everybody getting married, I'm not undergoing treatment. Females. So
Mm-hmm.
naturally, females we have a protective social environment. So if they have a cancer, so the female naturally young females naturally prone to mood swings. Again, the treatment situations. For example, if it's going to be organ loss, so if you're taking a throat out, if you're taking a stomach out, if you're taking a breast out, so the functional loss, the social inhibition, it will give a distress. Then type and length of treatment also gives a mood swings. So the patient, if you have a fever, you go to a doctor, take the 5 pills. In fifth day, you'll be happy, you'll be relieved. But in cancer care, the treatment is quite prolonged. So the type and length of treatment, for example, around 6 to 1 year treatment will give a big headache for all patients economically. So mood swing happens naturally. Again, the advanced stage disease. So the patient will be having what to say, hugely depressed, having pain. Poorly controlled pain also gives to a mood swing. Again comes the lack of family support. So for example, praying females married, so having a breast cancer diagnosis, ovarian cancer diagnosis, then society inhibition, family incoordination, the caregivers mindset, that also gives a mood swing. So basically the mood swing, it's quite distorted in the real world practice, but still if you communicate with them properly, for example, it's a difficult conversation regarding mental health, okay, so we should give them clarity, hope, make them feel light. So I usually sit and talk with them, so ensure that I'm with your journey, don't worry, the compassionate word and little bit of encouragement for small achievement. We will tell that the patient, so your cancer has responded beautifully, except in one or two sites. Instead of telling that you haven't progressed. So this kind of compassionate words, it gives them some kind of hope to live on. So they will stick on their treatment. We can achieve many things without disturbing the quality of life. At least giving them a stress-free mental mindset. So not mental, stress-free mindset. So the mental health issue in 100 out of 100 patients, 85% will be there. So if you treat properly, if you have a good psycho analysis or any psychiatrist support, any de-addiction, everything matters in this. So regarding the mood swing and psychiatric behavior, it is poorly understood. If a good doctor can identify or pick up early, I think it should be managed in a proper way. It is almost negligible. We can figure it out. We can treat it out. It is not that that bad that we will lose the patient, we will lose that. But in proper communication, only the matter is communication. You sit and talk with the patient, they will open up. You can identify the what the crux of the problem. We can solve the problem. Without communication, without identifying the problem, it's going to be a tough task for both for physician and patient in the cancer care.
Yeah, sure, doctor. So, doctor, next we have is from Nehal Patel, and she would like to know if there are any dietary restrictions for cancer patient undergoing chemotherapy.
Dietary restrictions. So I will tell that Mediterranean diet boost immunotherapy. It was the article shared in JAMA, Internal Medicine in
Mm-hmm.
2015. They told that Mediterranean diet boost immunotherapy response. It means that simple, adding extra virgin coconut, extra virgin olive oil in your food, it boosts up the immunity. So this
Mm-hmm.
was proven. This was proven. It was practiced in European countries. Another thing is Women's Health Initiative. They found out low-fat diet, some certain dietary modification, indeed have an impact. So they published that moderate dietary fat intake, moderate weight loss have a clinically meaningful impact on breast cancer outcome in postmenopausal women.
Okay.
We think that this getting more and more clinically relevant. So adding a what to say, low fat diet, going up with the
Mm-hmm.
exercise, having a Mediterranean diet. If you are a vegetarian, you just add on
Mm-hmm.
with the fruits, vegetables, whole grain nuts, and olive oil. If you are non-vegetarian, go ahead with the fish. So I think these are the things I promote. I don't promote a dietary restriction. I encourage them to have these kind of things. Another thing, obesity is an established risk factor for cancer. So I ask them to make sure that rather than losing weight, gaining weight is also dangerous because insulin is
Mm-hmm.
known to be promote cancer cells. So I
Yes.
think a proper discussion with your nutrition and following a Mediterranean diet and in general having a low fat diet, moderate weight loss in long weight will give many benefits for the patient who is taking chemotherapy.
Yes, doctor. Yes. So, next question is from Pragya Khanna, and she is asking, how long does it take to complete a course of chemotherapy, immunotherapy, or targeted therapy?
So three questions in one question. Okay, all right then. I try to answer this one.
Yeah.
So
So
let
she
me
is
take for
asking, I think, about the generic duration.
yeah, I will answer one by one.
Yeah.
So basically, for chemotherapy, depends on the site of the tumor, stage of the tumor, and patient profile. For example, for breast, it is around 6 months. For head and neck, it is around 4 months. Sorry, 4 weeks,
Okay.
4 to 6 weeks for head
Four
and neck.
weeks.
For example,
Mm-hmm.
for example, stomach or colon, it is around 8 months or 6 months of adjuvant therapy. This is regarding chemotherapy. Roughly, you can consider for chemotherapy 6 months. For
Mm-hmm.
for what to say, for some patient will extend for 8 months. Okay, for chemotherapy, it's a limited duration in curative setting. Regarding
Okay.
targeted agents, nowadays targeted agents are given till progression. For example, the patient is responding beautifully, you just give them till the
Mm-hmm.
disease recurs, give them. For example, the patient is taking pills for lung cancer. So the patient usual duration is we advise is 36 months. The patient is responding more
Mm-hmm.
than 36 months, we'll encourage to take them. Breast cancer also has two disease. That if the patient is responding stage 4 disease, responding beautifully through trastuzumab, so we just ask them to maintain with trastuzumab till the disease recurs. It depends on the practice to practice, but as per the universal suggestions and recommended guidelines, targeted agents, those who are responding, can be taken till progression, even till the next stage when the disease shows recurrence, it can be taken without any issues. Regarding again, in targeted agent, I will tell you regarding time limited therapy. For example, breast,
Mm-hmm.
it is 10 years treatment. Nowadays, they're telling previously it was 5 years. Now it is telling 10 years. For example, chronic myeloid leukemia, regarding targeted agent, they are telling lifelong. In RCC also, they are telling that you can take for lifelong also till progression. It means a lifelong means it's still progression. So till
Mm-hmm.
you are responding beautifully with the target agents, you can have it. So it's like a
Okay.
diabetes drug. So the diabetes
Mm-hmm.
until otherwise the diabetes out of control, you will be change the drug. Likewise, the simple concept. Your
Mm-hmm.
cancer is responding beautifully. You just stick on the same medication. You just prolong the treatment till the next recurrence. Coming to immunotherapy, as of current standard, it's a 12 months or 24 months of immunotherapy. So immunotherapy is quite costly. Another issue is with immunotherapy, the response is beautiful. It means that durable. What is durable? If you give immunotherapy for 1 year, the patient will have a durable response. They won't progress very easily. It means that they will go on with the response. You will wonder that when they will have a progression. That kind of biomissile is immunotherapy. For immunotherapy, my answer will be 1 year or 2 years of immunotherapy.
Okay, doctor. So, doctor, next we have is from Shimona. She is asking, does hair loss occur while a cancer patient undergoes chemotherapy?
Hair loss in chemotherapy. I will tell you. I have to explain this very carefully because this is the biggest question every patient is asking. Why hair loss? Why not hair loss? Why me? Likewise, you should understand that hair loss is will happen, but not with all cancer drugs. Okay, I will give you the statistics. I will give you the numbers. First, for hair loss, it depends on the treatment. Not all drugs causes hair
Mm-hmm.
loss. You should know that.
Okay.
Again, I stress the point. Not all drugs.
Okay.
Only handful of drugs will act on hair follicles. So basically, cancer chemotherapy sells all cells. So it will kill the cancer cell. So they will have a hair loss. But it is confined to 10 to 12 agents. Rest of the agents won't cause hair loss. It means that hair loss, what we are seeing is only 10 to 20 percentage. 80
Okay.
percentage we are treating the patient without hair loss also. Now the scalp cooling agents are coming up, but we don't have in our center. But still, I tell them to cope up with hair loss. I tell them
Mm-hmm.
only three things.
Mm-hmm.
You should understand that hair loss will happen. It's a common side effect, but it is a reversible side effect. You should
Yes.
understand it is reversible side effect.
Mm-hmm.
Second thing, it is rarely permanent. It is rarely permanent. So we are
Mm-hmm.
giving only for time duration. Time duration therapy, it may be 3 months or 4 months, 6 months of chemotherapy. After that, they will regain the hair.
Mm-hmm.
Another, coping with hair loss. So how do you cope up with hair loss? We have many things. We can use a hat, we can use turbans, we can use wigs,
Yes.
then psychological support. So the
Mm-hmm.
patient, they won't fear of recurrence, they fear of hair loss.
Mm-hmm.
So I ask specifically for a patient whether you want to cancer to recur or hair to recur. Everybody will take the, okay, doctor, hair will recur means I will take on this. Cancer recurrence is dangerous. Hair recurrence is rarely permanent. Most of the patient understand the problem, so the emotional challenge associated with hair loss doesn't affect the quality of life. Again, I repeat, emotional challenge associated with hair loss doesn't affect their quality of life if
Mm-hmm.
you explain properly regarding the hair loss, because
Mm-hmm.
it is a rarely permanent, it is reversible side effect, it is not caused by all agent. You should understand the three things. So I convince them like this is my routine
Mm-hmm.
practice. So my female patients are happy that, doctor, you just cure the cancer, the hair will grow again. I prescribe the medication for the hair, then I can refer them to wigs. I can usually I don't advise them to shame on the hair loss. I tell that hair loss is not a taboo. The hair will grow again, so you'll be happily going to beauty
Yes.
parlor or maintaining your hair properly. So don't bother.
Yes. Yes.
That's my
Yes.
usual practice. That's what I convey to viewers also.
Yes, doctor. So, doctor, next question here. Rohini, Miss Rohini, she's asking target therapy successful in cure of cancer. Is target therapy successful while treating cancer while in cure of cancer?
Yes, definitely, because success rate is gauged by three things.
Mm.
So the cancer should not recur, the cancer should be under control, cancer should disappear.
Yes.
So disappearance is complete response. Maintain its maintenance therapy.
Mm-hmm.
So control, it means a stable disease. So it has different meanings in different settings. So for target lesion, for example, in CML, the patient will be taking the drugs lifelong. The patient will be taking the lifelong. It is rarely curable. Sometimes it is curable for some patient also. It depends on the
Mm-hmm.
situation, depends on the disease, depends on the setting of treatment also. If it is stage 4 disease, the targeted success rate is gauged by 3 years. It means that the patient without disease for 3 years is a success rate in different setting. It means in stage
Mm-hmm.
4 it is different. In stage 2 it is different. In hematological malignancy success rate is different. So
Mm-hmm.
in general, the targeted agent success rate is there around 30 to 60 percentage compared to chemotherapy. It depends on the stage of the disease. It depends where you treat. Depends on the agent what we are using. It depends on
Mm-hmm.
the toxicity profile of the agent, then physical profile of the patient. So
Mm-hmm.
the patient, for example, targeted therapy, hormonal agent in breast cancer. Now in stage 4, I'm telling about stage 4. The patient has a disease, the bone, liver, lung. Is a hormone receptor positive disease. Now we have a CD4K inhibitor, CDK4/6 inhibitors. You give the
Mm-hmm.
patient for 3 years, they live for 5 years. It means that treatment for 3 years plus 2 years bonus for 5 years. So
Mm-hmm.
this success rate is not gauged by in general. It is defined by the patient capability of taking the drugs and response of the agents what they are receiving. So the targeted agents, the success rate is huge compared to cancer chemotherapy.
Mm-hmm.
It depends on the settings, depend on the stage, subtype, and variants of the cancer. So my general answer will be the targeted agent success rate is there. It is huge. It is growing up. So the new
Mm-hmm.
data, maybe after 5 years, once I am speaking with you, we can tell
Mm-hmm.
that targeted agents may cure the cancer.
Yes. So next question is from Lily Rose. She's asking the role of medical oncologist in radiation therapy.
Yeah, definitely. Our role is there. So in concurrent
Yeah, yeah.
setting, it means that for example, I'll give you examples and I will elaborate. So in head and neck cancer, concurrent chemoradiation is the standard of care. So what radiation oncology they will plan, they will send us for the concurrent. It means concurrent means simultaneously same time. So we give a chemotherapy weekly basis or 3 weekly basis to enhance the effect of radiation therapy. For example, in the head and neck, cisplatin high dose, it means that 100 milligram per meter square is equivalent to 10 gray of radiotherapy. It means that five fractions. It means that this one dose given for 3 weeks, it means 100 day 1, day 22, day 43 will be equivalent to 10 gray. It means that 5 days of radiotherapy, it will the boosting effect. It also enhances the local control. So our role of medical oncologist radiotherapy is there. It depends on the setting, depends again in the esophagus also, we are using concurrent chemoradiation. In lung also, the stage 3 um, inoperable cases, concurrent chemoradiation is standard of care. In small cell carcinoma, concurrent chemoradiation. Wherever the concurrent chemoradiation concept goes, the radiation oncologist will follow the medical oncologist will help the radiation colleagues to have a better response, better outcome for the patient care.
Okay. Okay, doctor. Next question is she wants to know the role of chemotherapy in palliative care. So, which you have already explained, but if you
Yeah,
can.
I will explain elaborate. Don't bother. So, in palliative care, there are two things we have to keep in mind. Whether we are giving drugs to ease the symptoms or ease the pain. So, symptoms in palliative care is depend on two things. So, burden of disease. If the patient has a huge burden of disease, excellent performance status, we can use chemotherapy either as a metronomic chemotherapy. For example, nowadays the Tata Medical Center protocol head and neck is a huge hit among oncologists. So, metronomic chemotherapy means is a mixing of drugs, a cocktail of drugs in low doses of prolonged period of time. It will give a symptomatic relief. It will prolong the quality of life. It won't cure the cancer. You should understand that, but it will preserve the quality of life. It will preserve the performance status. It won't steal anything from the patient. Just enhance the patient quality of life. That is our motto in palliative care. And in another aspect of palliative care is, for example, if the patient is very much sick, a sick moribund means we won't use the chemotherapy in palliative care. It's just a supportive care. So in palliative care, there are two things. One thing is to consider is whether the patient performance status is making what to say. If performance status is making us to treat the patient, or if the performance is bad enough, so we cannot touch the patient. So in palliative chemotherapy, most of the medical oncologists around the world, the palliative chemotherapy is a bread and butter. So all stage 4 disease, palliative chemotherapy plays a huge role, provided the patient has an excellent performance status. The palliative chemotherapy will prolong the quality of life. It will ease the symptoms. It will maintain the disease. For example, in colorectal malignancy, if the patient comes to stage 4 disease, we have a 3 years to 5 year overall survival. Even in breast cancer also, we have a 5 year overall survival around 30%, 30 to 40%. Even in ovarian cancer, even in whatever cancer you take in stage 4 disease, palliative chemotherapy is the standard. Even in palliative care also, in palliative care, the metronomic chemotherapy has taken a world by landslide. Now before the month in JCO, uh, metronomic chemotherapy, there are huge comments because we don't have a randomized data on metronomic chemotherapy. Still, even the Chinese people, even the Spain people are eyeing India. They are telling that how it works. It works miraculously. My personal experience, metronomic chemotherapy, one patient with head and neck cancer, we use for 1 year, usually with horrible what's horrible is he got a very bad disease with lung, liver, brain, every meds. You name the organ, he has meds. So we used the metronomic chemotherapy, pain free. He lived for 1 year, 1.5 year meaningfully. I'm telling meaningfully. It means that less hospital admissions, preserving the quality of life, easing the symptoms, economic cost, everything matters in palliative care. So the
Okay.
role of chemotherapy is still there in palliative care. It will be there. So still, we have an expanding role of targeted agents and immunotherapy in palliative care. So the palliative care should be coordinated. Palliative care concept is early palliative care. It means a concurrent palliative care. So we should enroll the patient in the day one while they're receiving chemotherapy. We'll enroll the patient for palliative care. So concurrent palliative care with concurrent medical care under a proper oncologist, stage 4 disease still manageable, still the patients are salvageable, the hope goes on. So still we can, medical oncologist using a simple chemotherapy can prolong life for the patient, provided the patient condition accepts the chemotherapy, provided the disease is responding, provided if the communication between the patient and family, if they are accepting the proper care, so we can give what to say, we can allow them to die with dignity without suffering. Likewise, many roles are there. So I think that chemotherapy still has its own valid role in palliative care.
Yes, doctor. So, Rohini, Miss Rohini has a question again. Now, this time she is asking, what are the causes of cancer mostly affected in youngsters?
So we can't pinpoint only youngsters, but in general, I can tell you nowadays HPV associated oropharyngeal is coming in youngsters. So in our country, rarely HPV vaccination is used. So HPV oropharyngeal, HPV cervix cancer are coming up. Again, the smoking. Now we are moving from smoking tobacco to smokeless tobacco. So I think that smoking also is quite high among the youngsters. So it will contribute to mostly head and neck, and the sexual activities will promote oropharyngeal and cervical cancer. Another thing is obesity. So obesity nowadays, the this is a silent killer. Obesity will cause us high insulin level in blood. Insulin is a mitogen. It will promote all the cells to cancerous cell. So now, previously the esophageal cancer is squamous cell. After the obesity, it becomes adenocarcinoma. Likewise, many things are happening among youngsters nowadays. The young breast cancer patients are huge. It means that they are also having a very bad disease, triple negative HER2 disease. So the rise of cancer among youngsters, I divide into three reasons. One is the lifestyle, smoking, alcohol, addictions, and unprotected sexual activity or erratic sexual activity. These are lifestyle causes. Second is genetic cause. My family history of cancer, breast cancer, ovarian cancer, pancreatic cancer, prostate cancer. Another thing is the familial issues and the genetic. So genetics divided into familial, non-familial. So it's traumatic. So any person having a random mutation in the body, they have a chance of getting cancer. So these are the things mostly affecting the youngsters. Right now, the active lifestyle among the youngsters and de-addictions and even the 24-hour shift. I want to stress again 24-hour shift. They're working for night shift. The night
Yeah.
shift again causes changes in the biorhythm. Even the changes in biorhythm is making huge impact in the hormonal changes that leads to erratic hormonal changes, which gives to hormone-related cancers. That is
Okay.
also a concern. Even the mobile phone. Nowadays they are telling mobile phone usage and brain tumor. Still it is unproven, but I don't know whether maybe the data will come up in after 10 years. So I don't know about the mobile phone usage and the cancer. But these are the most causes among youngsters. The best studied causes. I'm telling the best studied causes, valid research.
So again, next question is from Miss Rohini. Now she is asking, what is the difference between adjuvant and neoadjuvant chemo and their benefits?
Okay, I will explain neoadjuvant first. Neoadjuvant before surgery. So it helps in downsizing, making inoperable to operable. Adjuvant, it's after operation, after surgery. The benefit is in neoadjuvant makes inoperable to operable, so we will attempt cure. It means that downstaging, downsizing, 4 centimeter, 1 centimeter, stage 3 to stage 2. So that is the benefit of neoadjuvant. Adjuvant chemotherapy, some microscopic systemic disease. It means that some kind of cells will be scattered in the body. The microscopic systemic disease will be taken off by the adjuvant chemotherapy. So overall survival. It means that 5% to 10% overall survival. Overall, the patient survival will be prolonged with adjuvant therapy. See, neoadjuvant also the overall survival is there even in breast cancer. If you give a neoadjuvant for even 1 centimeter or 2 centimeter operable breast cancer, depends on the response. Their overall survival is prolonged. So many studies already have been validated. It's a routine practice in our center. I think universally every oncologist will be following that only. So this is the basic difference between adjuvant and neoadjuvant. Neoadjuvant means before surgery, making the surgery without complication, downsizing the tumor. Adjuvant after surgery to kill the microscopic disease.
Yes,
Both will
doctor.
improve the overall survival.
Next is from Albert, and first of all, he's thanking, and he's thanking. He's thanking the entire team of us for organizing this session. So thank you, doctor. Thank you so much.
Thank you so much. Thank you so much.
Next is Dr. Raghu. He's also appreciating this FB Live. So, Mr. Akhil Dave is also saying that very insightful session. So, I think our viewers are really happy with this FB Live.
Oh, it's excellent, excellent.
Yeah, 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 a lot of comments are pouring in. Yeah, so thank you so much, Doctor. Thank you so much for delivering such a wonderful and insightful session. Thank you.
Thank
It
you.
was a privilege to have you here.
Thank you so much. I should
Yeah,
thank our own CBCC team for organizing this, what to say, education initiative for the, what to say, to pour the knowledge to the people who are in the
thanks to
social
you.
media. Even social media is a double-edged weapon. Even in social media, I request everybody to promote the positive news, to promote positive things about cancer, because many people's what I understood from my little social media experience, the social media has a huge impact in particularly in disease. So if you promote a, what to say, promote a center, it will be hit, it will be a miss it also. So even in cancer care also, I urge all the youngsters in social media to don't fear the cancer, just
Yes,
promote awareness. Make sure everybody goes to the consult checkup or any kind of cancer screening program. Our screening program is very bad in all over India, so that should be taken care of by the youngsters. The social media should be used for good good activities to promote the cancer
yes,
awareness,
sure.
promote the cancer screening. For treatment, see as usual, the CBC is there. We'll take care of the treatment. Thank you so much.
Yes, yes, yes. Thank you, doctor. So, guys, if you or someone you know ever need a cancer consultation, you can definitely visit Dr. Arun Raja at Dr. G. Vishwanathan, CBCC Cancer Center, Trichy. Thank you so much, doctor. Thank you so much,
Thank you so
everyone.
much.
Yeah.